And I'm gonna go ahead and get started because I don't want to waste people's time. Everybody knows everybody. We don't need to go through introductions, do we? Rebecca, you feel like you know everybody?
Yes, I'm sorry. I cannot figure out why my camera won't work. So you'll just have to deal with.
Well, we can deal with it as long as you can deal with it.
Sorry. Yes.
No worries, no worries.
Turn the light on.
She's always in a closet when we meet with her. I don't know.
Oh,
That therapeutic court, they really need to up their game.
That's why I said that. She's in a closet. So
Okay, so on our agenda today, my goal is to just quickly update folks on actions that we've taken since the last meeting so that we're all on the same page. Then I'm going to have Dunya, oh yes, and we've got Dr. Karlbaum here. They're going to give a bit of an overview of some thinking that we've been doing around the possibility of chasing a Rural Health Network Development Program Planning Grant. And then I wanted to show you guys some of the BHAC. Well, they have a data report, which interestingly has some therapeutic court data in it that I just want to draw your attention to. And in general, as we know going forward, behavioral health consortium wise, one of the goals is that we work with the Behavioral Health Advisory Committee so that our data efforts are at least informed with and by each other. And one of the starting places is to show you all of the data that they presented us in, I think it was a meeting last week. Yeah, last week. And then there are a couple of other links of interesting stuff that they've got going on over the BHAC. Then we will have a quick look at data that Lisa is working on updating. Some of it is law enforcement data and some of it is Gabby from Believe in Recovery and the work that she's doing at EJFR, as well as I think there's 2 slides there that relate to that. And then I don't know how much time we're going to have, but we do need to answer the question of what data are we going to collect, even in this period of us sort of being in between the grant and the data that it required us to collect and us defining the data that we're going to collect going forward. Is there anything that we've been collecting that we think is worth continuing, just so that we have long-term or trend data analysis capacity of things that we've been spending the last 3 or 4 years collecting? So with that, I'm going to share my screen quickly. Some of you have seen a version of this slide before. Some of you have not. Sorry, sharing. You guys see the PowerPoint slide? Great. Okay, I'm just making it so I can see you. Just quickly, a quick summary of our last meeting. The last meeting, we had a good discussion about, we wanted to identify, or some among us wanted to identify, and we all agreed it was a good idea, some specific population level questions for us to address as the data work group. And we were going to go away and sort of figure out the process for us to define what those questions are and who we need at the table to pursue that. We know that we want to incorporate therapeutic data, and some of the feedback that I got, especially from Brett, was around the possibility of tracking drug court entry, graduation, and recidivism within 5 years. And apparently there's a resource, the nationwide booking tool, that we might be able to get that information out of. It's just a matter of figuring out the resource and, you know, tracking that down so that we get it done. So there's some possibilities there. We wanted to address generally the sustainability of how we're collecting whatever law enforcement data we decide to collect, so that that is not the onerous thing that has been particularly on Brett, and it's something that we can feasibly do going forward. And then a great suggestion we had from Dr. Karlbaum, I think it was him, was to see about generating a summary report of the work that we've done data-wise for the BHC up until this point, to sort of mark it as a milestone now as we go into phase 2. So since the last meeting, and you'll see over on the right here, we've got links to all of that stuff in case you're just dying to go watch that meeting again. You've got a video, the meeting packet, and the Padlet links. Dunya and I met on the 27th of October just to talk a little bit more about defining population level questions. And you have some discussion notes there. And then from that, we, the Rural Health Network Development Planning Program grant RFP came out, and we got together with Dr. Carlbaum first, Dunya and Dr. Carlbaum, to see how we might structure some sort of a smaller network that could go after that grant and use it somehow on this definition of the population level questions that we'd like to look at, and figuring out where we might find that data, who we need at the table. Then we met on the 15th of November with the county, the hospital, Jim from DBH, and Dr. Carlbaum, the medical program director, to explore what teaming partners would make sense for the grant. And then we confirmed on Friday that Jefferson County Public Health will be a part of what so far looks like possibly a team of 4. We're also going to present a partner request, and when I say we, I really mean Dunya. Is going to be presenting that at the EMS Council on the 5th of December. So that will be 4 players together, and that's as far as we've gotten. But I think that's a pretty good, we've got a pretty good train of activity going here for the last month. And what I'd like to do is kind of turn it over to Dunya and certainly Dr. Carlbaum to talk a little bit about what the thinking is around the grant that we're talking about pursuing. You'll note in your slide, I've got one slide that's just an overview of what the grant is for, and a link to the overview and a link to the full RFP if you're interested. And then the next slide just gives a quick summary of our thinking, but I'm going to let Dunya, certainly, and Dr. Carlbaum tell us a little bit about what they're thinking as we consider pursuing it. Dunya?
Yeah. I hope all of you can hear me. I'm at home. We all have a stomach bug, so keeping my camera off today. So we've been talking a little bit about this. The inception of the BHC was really started with pretty much the same grant, I want to say in 2018, 2019, and was focused on opioids primarily. As we looked through the purpose of the grant, really focusing on making sure that the rural healthcare system is whole and complete to be able to take care of folks, we had started talking a little bit about MVPs, or multi-visit patients, and then also those patients that hang out in our hospital beds that we can't move on for any reason. I think that there's absolutely a behavioral health lens to this, which is why we have asked Jim at DBH to participate, but including things that are not only around sort of the more commonly thought of behavioral health issues, but also things around geropsych specifically. So geriatric dementia, we have a lot of patients that end up stuck in our hospital, or multi-visit patients for those kind of reasons. Whenever we're talking about the population level, what we had compared it to was more of a very specific identified group of patients that we would do case management around those individuals. However, we thought that it would be too difficult to get all of the legal requirements around that, where we could share information across entities. So instead, looking at it as population level interventions for that group of folks on both the MVP and the difficult to discharge side. Dr. Carlbaum, did I miss anything?
No, I think, we've all really hoped for sort of a case management like thing, and I think it's just too hard and too challenging to have someone who's psychiatrically unstable or behaviorally health in crisis to sign, like, here, sign these 20 pieces of paper, don't worry about reading them, right? That's kind of none of us would probably sign any of that. And trying to create a unified release of information, we didn't feel like spending the next 2 years of our life with lawyers. So we thought focus on population and identifying the right population, which obviously is hard, but we should just start somewhere and then identify that population, and then we have sort of a baseline measurement, and we can all decide what are the important measures, and then thinking about that way when we do interventions, we can see how does this work. So I think we've done a wonderful job at the BHC of getting to know the spectrum of services and who each other are and what our passions are. And now I think it's time to start implementing things sort of in a logical way that we can measure its impact. And I think this is maybe the easiest way to do it. I don't know for sure. And that's why I think a planning grant is important, because we should be smart about how we approach this. So I'm excited. I certainly think the MVPs, I think, Dunya, you call them, or familiar faces or friendly faces, I'm going to call them familiar faces because oftentimes they're not so friendly to me when I see them multiple times in the ED or in the ICU at Harborview, those MVPs. Those familiar face patients might be a perfect focus. And I also think the focus, Dunya, that you explained with the sort of patients stuck in the hospital, I think a lot of our pre-hospital providers don't have a complete understanding that in the river of patients that are flowing, that if the hospital gets dammed up by a beaver dam known as obstructionistic behavioral health referral places around the state, that then the creek overflows and then all of a sudden, instead of being ankle deep in patients, we're all knee deep in patients, and it doesn't really work.
So to underscore, this is a planning grant that we will figure out how we're going to collect the data that shows that we've got a question, we'll have data that gives us some answers, and then from there we can figure out what is the game plan that we want to put in as a result of what we've learned from that data collected. Are there any questions, thoughts? Gabby, welcome. Good to see you.
Thank you. Sorry I was late.
Oh, no worries. Any questions about the grant, what we're trying to do with it, who we've got on it, in terms of who we're trying to get on it in terms of partners, or how it fits with the Behavioral Health Consortium? Does all of that feel pretty clear? Okay. All right. Then I'm going to thank you, Dunya and Dr. Carlbaum. I'm going to go ahead and.
Hey, Lori, I want to, I don't know, I think Lisa just unmuted, so I'm not sure if she's about to say something.
Lisa, please.
I was trying to figure out how to raise my hand, but I didn't do it. So. Yeah, true. I guess I was trying to figure out how to electronically raise my hand. I love that idea. When you're talking about the, and I don't know if this is just also part of what will happen during the planning, but when you're talking about the frequent, so we have another term for the frequent flyers. Do you know, are you thinking that the work of the BHC will, I'm trying to figure out how to, because again, we were hoping we could figure out a process where we could find out if, when the same people were hitting the same areas throughout the consortium, which is a lot of the issues that you raised about not being able to necessarily do that. So when you're identifying those patients, is it going to really be from a place of the hospital, or are you trying to, and when you try to define the population, are you going to try to pull from all these different entities again? Or I'm just trying to get my mind around, is that part of what the planning is, to figure out how we identify that pool to be
I'm going to
able
let
to
Dunya, as the person with, I think, a master's of public health, or at least a master's of epi or a PhD in epi, I'm not sure, answer that as someone more wise than me.
I really doubt that. Dr. Carlbaum, but thank you. So I think that most likely what we will probably start with is our emergency room, just because it is the easiest data that we are going to look at. One of the things that I'm interested in this planning grant is it most likely won't only be behavioral health patients that we are seeing as multi-visit patients in our healthcare system. Some of the most frequent flyers that we have are people with out of control COPD, out of control wounds that they just can't control. Those are often associated with diabetes. And so it's going to be a little bit broader, and we need to think through what other entities, in addition to the BHC players, could potentially fit into this space. But I think that's the exciting part, that it's a planning grant. That being said, I'm open to all of it as well. And we have Jim as part of the network, because I'm sure that he has MVPs in his world as well, that he sees in our world.
Right.
And I guess for me, Lisa, the hospital just has such a huge database of patients that might be the most efficient start. Right? We can always try to get more data, but I'm just not sure, like, is it really worth, Brett burning the midnight oil, working from 2 to 4 a.m. searching for things, when there's a more efficient way to get the bulk of it, and then see if there's a particular group that's missing, and then go after that more specifically.
Yeah, that makes sense. I was just curious.
And hopefully with this starting place being relatively concise in terms of how many players, we'll be able to get a foundation built, whatever it is that we decide it grows out, blossoms into. It'll be nice to have a small group that we're working with who has a good idea of where the data is, and we can work really hard at getting some consistent both entry and output from it. Any other questions? Okay, moving on then to the BHAC. So I think most of you guys know the BHAC is the Behavioral Health and Behavioral Health Administrative Community. What is it? What does the A stand for, Gabby?
Advisory committee.
Advisory, thank you. I was like, I'm sure it's not administration. The advisory committee. So that's the group that handles the distribution of the 0.1% fund, which is also known as the Hargrove Fund. And they, at their last meeting, which was also last week, gave out or presented a 2023 data report. And so one of the things, so I've included, oh, I'm staring at my screen like you are also looking at my screen, which is not the case. How about that? Better? So if you click this link, you'll go to the full report, which is absolutely worth, going through and seeing what they have there and understanding that the data that they're collecting is for programs that they funded. So they don't get all of the data from, I don't know who, a Discovery Behavioral Health. It's specific to the programs that they're funding Discovery Behavioral Health for. But one of the exciting things that I found in there, and Rebecca probably knew this all along, is that there was some therapeutic court data in there, which if you click on this link, you'll go to a full page of information about therapeutic courts. But one of the things that I was immediately aware of as I looked at this at the BHAC meeting was how it shows how we've had our amount of folks that we're able to intercept through the therapeutic court, particularly the drug therapeutic court, how it has gone down. And we know that it's, legislation related. But it's really nice to see one thing connected to the other. I think a lot of times we either collect data and we have no idea how it really relates to boots on the ground or what influenced those trends. And this is a nice thing to see clearly. And I'm really happy that the BHAC had that data in this book or in this report. So I encourage you to go look at that more deeply as we go forward and we start looking at how we can really work in a collaborative way with what the BHAC is doing. Understanding the data that they collect and understanding how we can leverage what they're collecting better here and how what we're collecting can better support their awareness as they're distributing this funding is something that we're really aspiring to. So then the next report that they had is not really a report, but an example, and I'm going to pull it up over here and put it over here. They have some dashboards for the data that's being given for the programs that they are supporting. So it's not all of Believe in Recovery, but it's for the programs that the BHAC is supporting. They have all of these dashboards set up, and these were created by Kitsap Public Health. Yeah, Kitsap Public Health has an epidemiology team, or had an epidemiologist who worked with the BHAC folks to develop these dashboards. And I'm not going to click into every one of them, but it is interesting, the data that they've got there. And while it's not massive amounts of data, it's massive amounts of data probably for the people who have to get it in there every, I don't know if it's 6 months or a year or however often they collect it. So I think that would also be something worth familiarizing ourselves with as we think about how can we be supportive to their efforts and how can we use what they are collecting in our efforts. Any thoughts off the top on that? Very quiet. They say to count to 12.
Lori, I loved it. I love the links that went to Tableau, and obviously Tableau is super cool for visual learners like me. I'm a very visual person. But I do worry that the Tableau sheets were created by a single human, and I'm not sure if they're maintained or if a link were to break, what happens, because my understanding is that human that made it is moved on to some other role.
Oh yes, Amanda did. I don't know if I need to dig more into, I'm sure they must be paying for some ongoing something, but you're right. That's something that I should find out and know better and bring back to you guys. Other thoughts? Lisa? Lisa?
I learned how to raise my hand. I think the other interesting thing when I looked at that list is just this concept of how are we going to share data, because they're asking the same people that we're asking for data. You know, it's just
Right.
that data overload for people that are getting asked from so many different places. I don't have the answer, but I think that when you do your last agenda item, Lori, I think that's important to figure
That's an
out.
important thing.
How
to think
do we
about.
make sure we're not overburdening people and able to share data in a way that's works for everyone? And I agree, make sure somehow we know that it's being updated and accessible and all that. That's because I could see some of the things we asked for on that list. So
in answer to some of that question, the thing about the BHAC's data is if they did fund you for a 2-year period and then didn't fund a particular program the next 2-year period, they don't continue to collect the data, obviously, because the entity isn't beholden to give it. And so is it that we have some sort of a flow where if they are getting funded and they are providing this data, somehow we can get that data from the BHAC, but if they aren't being funded by that, but we are doing, you know, whatever it is that we decide to do, that whatever data it is, it gets consistently put over in the BHC's vault of data. And then again, we've got to come back to what are we collecting and what does it make sense to collect? Because you're absolutely right. I have no desire to overwhelm people with data collection, but whatever we are collecting, we want it to be useful, to be really giving us the opportunity to generate the insights that are going to allow us to better serve the folks here in the community. So good thought. And then the final thing, which isn't something you guys usually think about, but this is the school-based health center's final data report. And there's interesting stuff to note there. There is something called the Healthy Youth Survey, which this is different than the Healthy Youth Survey. This is just the school-based health centers that are here in Jefferson County. And one of the things that's very interesting is how the mental health services, counseling and mental health services are either increasing or decreasing, and what we're seeing in our most youthful population, the opportunity where hopefully we would intercept as early as we can to get services so that we manage different trajectories if at all possible. So
and Lori, thanks for sharing that. I thought that was the most interesting, and I wonder if that's a group that we don't capture very well in the clinic and Jefferson healthcare data, because kids tend to avoid the doctor or they're not sick, and so that was one other avenue. I wonder if once we get settled, if that could supplement it somehow, because I found that super interesting.
you're right, we don't have any school district people. We have Jefferson County Public Health, but we really didn't focus on school-based health center mental health side of it. So there's an opportunity there to both better define and tighten how it is we're weaving it all together. They do great work there at the school-based health centers. Any other questions on data that I've pulled from the BHAC or things you wish I was thinking about, digging into?
I guess, did they explain when they showed that or handed that out, like sort of like do they clean that data? Is it verified? Like, do we know that that's good data?
So the
thing
data, at least on the mental health part, and I only know this because I talked a lot with Susan O'Brien about this. They are filling out, they call it a half sheet for every visit that a kid is making, but there was, I don't know, maybe certainly during COVID and maybe in the year immediately following, there was sort of a kerfuffle about how all of the counselors were being funded. And I think it was Denise Banker at Jefferson County Public Health. She did manage to sort of weave together a bunch of different funding sources. But in the process of that, where I'm getting to with this is I don't know that funding that came from OESD required their counselors that were being funded by that money to fill out a half sheet. So I think there might be some question as to how consistent our data is maybe during that time period. But I do know that right now, all of the counselors are providing that data no matter who they're getting funded by. At least all of the counselors who are represented in the school-based health center report. So long-term trend analysis. I don't know if we can depend on it, but our goal is to be much more consistent about it, from like, say, beginning of this past school year forward. And before you take my word on anything that I just said, it would be worth us talking to Susan so that you're getting it straight from, not the horse's mouth, but straight from somebody who's actually doing the work. But that is my understanding of it right now. Okay. Jumping ahead quickly. So this brings us back to what data should we continue to collect while we're in this interim period of grant being done, haven't really defined what we're going to do for the population health thing. Is there anything that we have collected that is worth continuing to collect, or to try to improve how we're collecting so that we have trend data that can take advantage of the fact that we've been collecting whatever we have for as long as we have? And I'm going to start, the reason why I put this little thing, which isn't ultimately applicable, is because it had all of the different areas of folks that we're collecting data from, or that we would like to. So let's start with law enforcement. We have law enforcement data, we have jail data. So those are two different arenas of things. The jail data was coming both by the jail and by a program that Gabby is running in there, which I want to call RSAT, but that might not be the right program. But so do we want to continue collecting? Let's just start with Brett's data, the data that we're getting from officers. Brett, what do you think?
Well, it depends. So so we obviously collect it now, but as we know from the statistics that they're a little off, and trying to get that to be accurate is going to be very difficult for an officer's perspective, just because they go from call to call to call. Sometimes they just don't maybe know the person, or they just don't have time to do it correctly. So it's done swiftly. The jail is going to be a lot more accurate. The difference, though, is that with our jail data, there's a lot less people going in jail now. So you're not collecting any of that data. So I'm not so sure what the best way is. I mean, overall, as long as as long as it doesn't change throughout the years, statistics are fine if they're behind, as long as they're always that way. It's when I think we noticed in the Port Townsend's data now, it's gone. And that's because it's been, 100% vetted. Yeah, I mean, obviously it's not sustainable. It's not going to be 100% accurate. We can get it more accurate, I think, but it's probably always going to have a 20-30% error rate in there,
Right. Others, as you think about what value we have or could be getting from law enforcement data, considering all of the caveats that Brett just outlined, do we want to continue trying to collect that data, collecting it in whatever shape and condition it's in? Or do we want to put that on hold for the moment? And I'm looking around at all the brilliant minds. I'm not trying to make a decision myself.
I'm definitely interested in still understanding who is going into the law enforcement system. And so even if it's just demographic data, especially through the jails, I think that is accurate enough. Maybe less so with the, you don't use diagnosis codes and all of those things, but even for people that aren't there for a reason that we might have considered in the past to be part of the BHC scope, I would still be very interested in understanding that population of who's using our system.
I don't know the right answer. I was thinking about that, is like, how can that inform our project? And if the project is to understand the root cause of challenges and in people that are underserved, maybe that would be important to learn about demographic data of who's ending up in jail. Even if it's to show that it's because there's no housing that people end up in jail, because they're, doing stupid stuff to try to get money to, pay for housing or something. I mean, who knows? Obviously it's not that simple. I think that would be important. I do wonder about the jail being more informative than the officers, just because I don't want Brett to have to burden his officers with more tasks. You know, their primary job, from my point of view, is to come home alive at the end of their day, and their secondary job is to, you know, keep other humans safe. And I think that's a pretty big burden. And so I think demanding more from them
We're
may
coding more. Mhm.
not be feasible. And I guess I was just so struck by how different when you vetted the data it was than when it was sort of the raw data from the officers. Like I almost kind of wonder, like, I'm not sure.
Mhm.
Whereas maybe start with the jail or see, but I don't know. But maybe just getting the raw data of who's coming in contact with the law, like who's getting their name and date of birth, you know, written down might be interesting.
Go ahead, Fred.
I was going to say, in a law enforcement perspective, how we always gauge that stuff is through the crimes, right? You know, how many theft threes have we had? How many burglaries? Because those are always drug driven. Those are always drug driven, sooner or mental health, but they're always one of the two, right?
Right.
And that's typically how we gauge it from law enforcement wise. And that way, and those are easy numbers to see throughout the years because we report them every year to WASPIC. By the time those numbers come in, those aren't street numbers. Those are numbers that when the officer comes in, sits down, writes a report, attaches a crime to it, it automatically goes. So it's not stuff that's done in haste. So that's a lot more accurate. The crime part of it is way more accurate than the calls, because out of the 1,000 calls that an officer goes to a year, he might write 75 case reports on. Right. So the vast majority of those are calls that there is no case report for because it's a traffic stop or it's just a neighborhood dispute that we're talking with people on, and it's not necessarily a crime. So I don't know if we can incorporate that, but that's usually the marker, I think, for most criminal activity is those two types of crimes. The trespassing is another one. I don't think that one's a state tracked crime, but we do track it in our internal system pretty accurately.
That's an awesome idea. I love it.
So what I hear is pivoting might be too strong of a word, but a leaning toward the statistics that we can gather around what were the crimes committed, which are determined in a less, spur of the moment environment. And are we thinking that we'd like to set aside the trying to figure out the encounter or trying to track encounter in the field? Because this other would be far more useful. And it would get to the question that Dunya was talking about. And we know, so that's from law enforcement, not jail, or law enforcement in addition to jail. But I do know that the jail data, we're pretty confident about what we're getting with the jail. Dave Fortino gives us excellent data. Gabby, with the work that she's doing in the jail, gives excellent data, which also gives us, when we were collecting it for PIMS, we were collecting what services they were connected with. So there was a service connection element so that we could sort of vaguely at least track how someone is moving through our system. And Gabby, maybe we should talk about that. Is it a pain in the butt to gather? And is it and then for everybody else, is that useful enough for us to be asking Gabby for it? So let's start with Gabby.
Thanks. It is on your PIMS report. There's one page that I despise. I can't tell you which page that is off the top of my head. But I am happy to meet with you at some point and show you which page it is. It's very redundant, I think.
Is it the demographic page? How do you feel about giving demographic data? I'm trying to think about the different pages.
The demographic data is fine. It's a page of it, like
the one that we asked, or that was asked, how many got childcare services, how many got that. So it is the service connection that abhors. I just want to note this.
It is, because those are things that I can say, I'm referring this person to this service. Are they actually getting that service? not likely. They're in jail for one. And also sometimes people get out of jail and shockingly don't follow up with any services that have been provided to them or referred to them. And so that's a piece, like you're getting referral information. You're not getting service connection information because they're not actually being connected to those services while they're in jail. And then there's a piece about
insurances.
Yeah, the insurance thing I think is pointless in jail because people's Apple Health gets shut off. There's my kid. Surprise, he's in the car now. Guitar lessons are over now. That piece of it, I don't know that is valuable information while they're in jail. And then
there's some that looks at like how long has somebody been in MAT services, for instance, or any substance use support services.
Yeah, that one doesn't make sense for while they're in jail because that one, like, people don't stay in jail for very long anymore, typically, unless they're in there for a significant period of time and then they're on their way to prison.
Okay.
So that one is kind of pointless to track for jail services. For in-office services, it makes sense, but in jail.
And I should clarify for everybody listening here, Gabby provides us data that has to do with folks in jail. And she also has Believe in Recovery, which is actual services where people come in. She gives us plenty of data from that as well. And so right now we're focusing on the jail related data. But if you had thoughts, Gabby, as long as we're with you, about the in-office data, what
the in-office data all makes sense.
Okay. All right.
And it's data. I mean, you've sat with me while I've collected it. So it's not like super hard to collect. Once I figured out what I was doing, it wasn't
right.
It's not hard. It takes what, 15 minutes every 6 months. Like, it's not a huge
onerous.
Yeah.
All right. Thank you. So what I'm hearing is, just to recap on the jail data that Gabby is giving us, we could probably set aside the trying to collect who's connecting to what services because it's not really accurate. She can say they should go, but do they go or don't they? We don't really know anything more about how they're moving through our system. And Lisa, I see your thought, or I see your hand.
Yeah, I'm curious about that. So two things, and I'm not trying to keep burdens on people. It's just information that I find very interesting. So for Gabby's work, I wonder, the referrals are telling us, though, kind of getting back to what Dr. Cobham said about why, just kind of the burden of what people need. Why are people ending up where they are? What are the services that they're lacking that result in some of these things? And so I don't know if it's helpful to know. It could be something as simple as Gabby just saying, out of all the patients I see, 50% always need this, 40% need this, 20, so instead of, we're not saying, yes, they got those services, but here's what that population looks like would be interesting to me. And I don't know how easy or hard that would be for Gabby to provide. And on the jail part, one of the things that's been interesting with Brett working through some of this data now that he's done all this hard work is just I don't know, I hate to use some of these words I'm using sound so negative, but the burden of mental health and drug use on his officers. Because one of the things we've been playing with trying to analyze is the percent of their calls that are related to mental health, drugs, and substance use, and what the impact is that on his officers. And I was like, wow, I was surprised it was only 8%. And he was like, 8% is a lot. So, basically he said something much more intelligent than that. But it was just like, just understanding some of these bigger concepts. And I don't know for Brett's data, if there's a way to just not be so focused. We've tried to break it into really specific buckets, like this is mental health, or it was drugs and mental health, or it was this or that. Is there a way to do something? And it might not be. I hear what Brett's saying about the challenges of getting data, but is there a way to keep our finger on what is the the burden too, and is that important to other people? I find it interesting and fascinating. I think it's important data to know kind of what's happening with the law enforcement in the community. How is behavioral health, mental health impacting them? And also, if we could get good data, it's a good measure again of population health, and the things that we're doing to address some of these things, are they having an impact? So those are my two things on those. And I'm not trying to, I understand the burden of data collection, but I just would hate to lose some of that bigger context that some of those things could provide.
Thoughts about that? Thank you, Lisa.
And I was going to add to that, it's all, when you think about 8%, but I was just going to go over something today. We've had 33 calls for service today. And the first one's a traffic stop. Second one's a follow-up on a case. Third one's an alarm call. Fourth one's an abandoned vehicle on Frederick Street. And then another follow-up and lost property from someone on Milo Curry. And then we have a disturbance. So that one's probably drug related or some type of related. But then we have littering. That one's not really coded that way, but a lot of times that's what they are. They are, drug related. They don't have homes or money or poverty related or something of the sort. Then we have civil issue, traffic stop, criminal traffic, agency assist. So when you think of that, some people think of when cops do their job, they're just responding to these calls all the time that are involving criminal behavior. And, I would say out of the 33 calls, 7 of those are probably actually criminal related, and probably 5 out of those 7 are drug or mental health related, when you kind of break it down that way. And then when you really look at it, I have 3 cops on today. So each cop had to deal with somebody who was mental health or drug addicted, and 2 of them had to deal with 2 people that were that way. So when you think about it, and that's every day. So, it's just kind of, I don't know, the numbers don't really paint the story that well. But when you kind of look at it, we have prowlers. We've had like a prowler. Is it alcohol, drug addicted, mental health? Maybe, probably, but it's not coded like that because we just don't know.
So all of this is making me then go back to what Dunya was saying she was interested in seeing. Is there any, is it more of a qualitative? Is it an inquiry on a 6-month basis where we're asking rather than trying to get a count? I mean, Brett has a very good idea right now of what a day looks like. And if you did that times 30 in a month times 6 months, could he give us the same assessment in a qualitative but consistently questioned, or a consistent inquiry every 6 months, and we come up with some questions that help us get to what you're saying, Lisa, but it's not, I counted every last one. Is that silly when you guys are you're the data work group and I'm here talking about qualitative instead of quantitative?
No, I don't think that's silly. I wish and Brett probably knows better if there's, I don't know, there's a way to use the thing, because they are already, without us asking, right? You have always been collecting that mental health, drug, substance use. That was something that we just piggybacked on. If there's a way to look at that in a broader context instead of, and I don't even know time spent. I mean, there's interesting things. That's the other thing, is time spent on those incidents are going to be a lot longer. And I don't know what kind of, it's tricky. I could make you do all kinds of work.
That's a good point.
Demographics would be interesting too.
That's a good point, because time spent is significantly, I mean, I'm not going to do all those calculations, but but it's there. And just the call we had the other day, we had 6 guys on it for 4 hours, and then he went to the hospital, and there's another 2 or 3 hours there at the hospital. And it's certainly a lot more manpower intensive than a littering call.
What I like is law enforcement seems to be a magnet we keep going back to. Okay, so we did law enforcement, we did jail. Quickly, let's jump over to Rebecca and therapeutic courts. And I want you guys to hold in your mind the data that we just saw that they are already giving to the Behavioral Health Advisory Committee. Is what is being gathered there what we would like to see? And could we just I don't know. Rebecca, how complicated? Are you sending somebody a report that then gets put into something, or are you having to hand enter these all somewhere? That what we saw at the Behavioral Health Advisory Committee's report.
I'm entering quarterly data, and at the beginning of this, we kind of tried to, there was like maybe 3 times as much information that they were hoping to collect, that we really had to pare down because we wouldn't have been able to get past information. It would have absolutely just disrupted everything we've tracked before. So trying to be have some continuity about numbers, specifically about recidivism, because the data that I have maybe went back a year or 2. I don't know where that information went or anything, but when my position was created, we kind of started from scratch on how to do stuff. I've since gotten a new tracking system from the AOC that I'm hoping to implement next year, but it is pretty light on demographic information, except for what zip codes people live in. But it does ask if they have a dual diagnosis, if they're deemed just substance abuse or just mental health, or and what their drug of choice is. It does break it down a little bit, but it doesn't break it down much further.
And do I know the age of our folks going through? Like, can I get age demographic? Can I get, or are you already providing it? Maybe I shouldn't say can.
I'm not providing age at this point. It would not be hard to do though.
Okay.
We only have enough people in a year to say I can't get you that information. We have probably 50 this year that we've served, so I could totally get that for you.
Right. And we're not trying to make work for you. I'm just trying to think about what we would want. And anybody else who's thinking about this, what would we want from therapeutic courts outside of what we just saw in that report, which was sort of how many were there? I mean, Brett, I know you gave us recidivism, how long in the program? What was the other thing? Going back to my slide.
Currently tracking whether they're how long they're in the program.
Entry, graduation, recidivism within 5 years. And is this nationwide booking tool that Brett mentioned? Believe me, I didn't come up with that on my own. Is that where you're getting the data that you're handing into the BHAC, Rebecca?
I'm just getting it from my own records.
Okay.
So that's why, and Brett, you and I should chat about this at some point, is to how to use that, because the list that I have for BHC goes back maybe 2 years. The list that I have for drug court goes maybe 3. So I don't know who was entering this information before and where they got it from, but I don't have access to it.
Well, Rebecca deserves access.
So
to
prior
everything.
to you entering information, Ford and I were collecting data and giving it to Sophie, and she was entering the information.
Yeah, and all I have from her is like a list of names with their address, their zip code, and like when they entered, if they completed or not.
So it sounds like there's some
I
opportunity.
mean, I think.
Go ahead, Gabby.
I think in the past we were collecting insurance status. So if they had private or state insurance, what their housing situation was, and how many participants, and whether or not they had any sanctions. We weren't collecting a whole lot of data before.
So there's an opportunity to dig and understand what might actually be there, what we can get Rebecca access to, and what makes sense, because we're not trying to load up Rebecca or anybody else over at the therapeutic court. I think we just want to better understand how we're intercepting there and how successful we are or are not being, and how that ripples through the rest of our system, especially housing wise. I think that would be interesting.
We do track that. I forgot to mention if they're housed when they come in, and if they get housing through the program.
Okay, Rebecca, we're so glad you're there, and we're so glad you're here. Okay, moving on to the hospital, who I know is not in love with the PIMS report, but maybe not all of the PIMS report, maybe just pieces of it they didn't like. What would you guys like to see us continue and discontinue from what we've been asking of you for the grant for the PIMS report?
I'll let Adam speak a little bit to that, since I think it is was his crucible every 6 months to do.
Okay.
I guess I'm still having a hard time though, sort of separating what we would in an ideal world like to do versus what we're actually going to use these data for.
Mhm.
I still don't understand. Lisa, whenever I hear someone say, I think it's really interesting, I think that that's awesome. And then I say, that's not a good enough reason to collect data. Sorry. And so what are we actually going to be doing with this? Are we going to be informing the BHC in terms of programs that we'll be evaluating? Are we going to be identifying funding resources? Because I would really like essentially a research question.
That we're addressing.
Yeah, because I'm just having a hard time tracking what all of this is going to lead to in the end. Jefferson Healthcare, we're happy to provide. Now I am speaking for Adam. Sorry, Adam. Unmute your. I think demographic data is super simple for us to provide, and that includes things around geographic location, age, sex, race, ethnicity, language, coverage, all of that. In terms of substance use or behavioral health, mental health, and our ED are across the house, to be 100% honest. We're happy to do all of that. Some of the screenings we just couldn't provide, so there's no way I'm going to try even harder to get screenings. But I just want to get back to what are we going to do with this? I'm sorry if I come off cynical. I'm just having a hard time tracking.
Adam, go ahead. Thank you, Dunya.
Yeah, I'm kind of, Dunya said it a lot more smartly and intelligently, but I'm kind of circling around, you know, if we could have a focus statement that says, hey, what the reason we're all here meeting, what exactly are we trying to solve, or what are we trying to improve? Like in the most simplest terms possible, because I feel like we get muddled. Each organization has their own unique, complex problems to solve, and everybody's time is very valuable, especially the people out in the field. I feel like if we could stay centered around what exactly we're trying to accomplish by collaborating, if we can just keep it down to like, okay, we are just requesting, let's just for each department, let's figure out one event that causes them to put a bean in the jar and start from there. If we need to know some kind of demographic or something, inch by inch, but try to keep it as minimalistic as possible to make it as doable for each department. But like right now, I get so caught up in everybody's obstacles that I just keep losing it. What are we trying to do again? Basically the same thing Dunya said, but
the consortium and what the consortium was started to do, and what that last grant was hoping to help us do, was to better understand collectively our system. So you're right, every one of these agencies has complicated challenges that they're addressing within their agency. But as a collective, that our one client, or that the client that we all touch is coming in contact with, what we are trying to understand is how we can better serve that one client collectively, which I think goes to Dunya's idea of this. How can we look at the 50 people that we're addressing over and over and over again, and how we can address those 50. Now, I'm not saying it's 50, it might be more, it might be less, but the idea of taking it from a group rather than an individual. So that's the evolution that I'm seeing, between what we were doing and what we are aspiring to do going forward, or want to plan to do. But I think that having us all at the table, and whatever data we pulled together, I don't know that it was the data that did us any good as much as it was the conversations like this one that help us to understand what all of our siloed agencies were working with. Dr. Carlbaum?
Yeah, I think I hear Dunya asking for specific aims, number one, for our proposal, and I wonder if it's something to say, understanding the impact of behavioral health on systems of healthcare delivery in our community, or something like that. And then I think specific aim number 2 is going to be to do some intervention. I don't know what it is, that then and measure on that baseline. I mean, I feel like we're still working on establishing the baseline of what is the impact. And I don't know the most thoughtful or best way to say that, but I think that's what we're all talking about, is we're all looking at different facets of the diamond or different parts of the elephant, depending on which story you like to read. And we're just trying to define, like, what is the group of people, and maybe what are some of the root causes that we could then focus an intervention on.
Mm-hmm. And so, and that, I think, if we are able to go forward with this planning grant, we would begin to answer that. What I want to be mindful of is that has a very health, and it broadens it, you know, to the folks who have dementia. It broadens it beyond what the original behavioral health consortium was looking at. And it also broadens it beyond what that funding that we're getting to keep the consortium table open from the opioid, what is it, administration, opioid action council, I think is what it is, the regional action council, that's giving us that money to keep us going for the next 16 years or whatever, or at least keep the table open. So there's sort of we've got this table together, we're getting funded by some of that, which has pretty specific, you know, what are you doing to address substance use throughout your community? And the BHC will be leading, coordinating, planning. That's what it's doing. Hence our being collaborative with the BHAC, who is doing a lot of the funding of the programs that address that. Then as we look at what this grant could do, it could broaden our behavioral health look to look more at the mental health, the dementia, the specifics of how social determinants of health impact our the key demographic that we're looking at. So you see that I'm trying to balance, or I'm trying to make sure that we're covering both sides with what we're doing, so that nobody sitting at this table says, why are you getting paid opioid settlement funds to do X? And let's also make this table that's gone to the trouble of being together relevant as far as it makes sense to leverage it in ways that we can with our community on the social determinants of health, or just public health, population health questions that we have that are specific to our county. And I'm reading Dunya, who says, understanding the impact of people with behavioral health disorders have on our health and social service agencies, right? So then could each agency come back next month with what analyses they can provide that directly respond to this question, whether or not they were doing the PIMS report? How do people feel about that? Can you go away and ask and answer, what impact does your agency have? Thank you, Dr. Carlbaum. And we're about to go. I'm going to go ahead and take this question that Dunya's had made concise for us and send it out to folks. And then maybe I'll reach out to each of you individually to see if we can come up with an answer for that. I'm thinking that we should not try to have a meeting in December, maybe January. Same, what day is today? Same time, whatever number of the month. We're on the third Monday. Third Monday of the month, 2 o'clock. Brett hates Monday. Anybody want to go for?
Monday's fine. I'm just ill prepared for it.
Okay. All right. I'm going to do it the third Monday of January. I'll send out an invite. I'll reach back to you all with this question. That will be the topic. Thank you, Dunya, for putting it into concise words. That'll be our topic.
Lori, can you resend me the slides? The link I have doesn't seem to work from today.
Oh yeah, I'm sorry. Yes. Did it not work for anybody else? What
It worked for me.
Okay. All right. I'll do that. Thank you all. Have a great day.
Thank you.
All right.
Yeah.
Happy Thanksgiving.
Bye.